Good afternoon, colleagues. I think after that lunch, I need to speak a little louder and get your attention so that everybody's awake. I am Dr. Jessica Paken from South Africa, and I am an audiologist by profession, presenting why audiological monitoring is crucial for patients with cervical cancer. So you're probably wondering why uh, you're listening to an audiologist at a women's health forum when hearing loss is more common in males than females. And what does hearing have to do with cervical cancer? Hopefully, by the end of this presentation, you will have both of those questions answered. So this is my research team, Prof. Vikash Siuram from the head of the African Cancer Institute, Prof. Mershan Pule from Massey University in New Zealand, and Mr. Cyril Govender from Australia. And we work together on exploring cisplatin-associated ototoxicity and actually evaluating the feasibility of implementing an audiological monitoring program within the South African public health context. So cervical cancer remains one of the most significant threats to women's health and is the most prevalent or second most prevalent cancer in South African females. It's locally advanced cervical cancer incidence is, as we know, is also associated with HIV positivity, resulting in severe morbidity. Treatment of cervical cancer can include surgery, radiotherapy, chemotherapy, or a combination. And concurrent chemoradiotherapy using weekly cisplatin as a chemotherapeutic agent is the standard of care for locally advanced cervical cancer commonly diagnosed in our setting. So why is the incidence of cervical cancer so high in Africa and South Africa in particular? The high incidence in Africa is largely shaped by socioeconomic inequalities, poor access to screening, and the intersecting burden of HIV infection, which accelerates the progression of the human papillomavirus. South Africa, home to the largest population of people living with HIV, bears a disproportionate burden of cervical cancer, predominantly among Black African females. This population already faces systemic marginalization, and the combined effects of HIV and cisplatin-based chemotherapy amplify their vulnerability to ototoxicity. Okay, but let me take you a step back, because you're probably thinking now, what is ototoxicity? While cisplatin is one of the most popular anti-cancer drugs due to its effectiveness, it is known to have a diverse toxicity profile. It affects the gastrointestinal, the renal, the hematologic, and the auditory system. And although cisplatin's side effects on the other systems can be reversed or minimized, its impact on the auditory system due to the functional and cellular damage to the inner ear is medically untreatable or unpreventable. And this is actually referred to as ototoxicity. Well, cisplatin-associated ototoxicity is characterized by a pattern of bilateral, progressive, sensory neural hearing loss with a greater effect on the higher frequencies. Bilateral meaning it's in both ears. Progressive, it's going to get worse. Sensory neural, it's a permanent hearing loss. Effect on the high frequencies, that means they're going to have difficulty hearing speech, and especially speech in noisy environments. And we all know that this is the ideal listening condition, but out there's always competing noises. So a female who is on cisplatin medication is likely to have these difficulties. Okay, The incidence of cisplatin-associated ototoxicity is highly variable, and it actually ranges between 21 to 80%. And this variability is due to a number of factors, patient factors like age, other comorbidities, their pre-existing hearing, patient physiology. Or it could also be due to environmental factors, such as previous exposure to noise. Or lastly, it can be due to the cisplatin exposure parameters, such as the duration, the dosage, and the method of administration. So while cisplatin chemotherapy is the cornerstone in the treatment of cervical cancer, its ototoxic potential is well documented. However, audiological care for oncology patients remains underdeveloped in South Africa. Ototoxicity monitoring programs are not routinely integrated into cancer treatment protocols. And where guidelines exist, such as those of the Health Professions Council of South Africa, these are largely developed from first world models that may not necessarily reflect the realities of resource-constrained contexts. And this study was therefore designed to generate local evidence to support the integration of audiological care into oncology services and to actually assess whether such a program would be feasible, sustainable, and contextually relevant. So just to sum up, right, women receiving cisplatin-based chemotherapy for cervical cancer face a double burden. One, the threat of a life-limiting illness, and two, the risk of permanent hearing loss. Hearing loss, though less visible than other side effects, can compromise communication, employment, social functioning, and most importantly, mental well-being. As caregivers, breadwinners, and community anchors, women's health or hearing health directly affects the social and economic stability of their families. Yet in many oncology settings, audiological care is viewed as peripheral. This research actually sought to position hearing health as a vital dimension of holistic cancer care. And the study aimed to investigate the extent of cisplatin-associated ototoxicity in cervical cancer patients and to evaluate its feasibility through the implementation of an audiological monitoring program. And this was done through three interrelated objectives. One, which was to describe the perspectives and practices of healthcare professionals regarding cisplatin-associated ototoxicity. Two, was to actually determine the extent and severity of ototoxicity in this cohort of females. And three, to evaluate the feasibility of the audiological monitoring program within a public health sector. So this was a concurrent triangulation mixed method study, which was conducted at a tertiary level hospital in South Africa. And we had quantitative data that was collected from 29 healthcare professionals, including oncologists, nurses, and pharmacists. And qualitative insights were drawn from 4 audiologists. And the prospective data was actually elicited from 82 cervical cancer patients who were receiving cisplatin chemotherapy. And these patients were followed audiologically for an extended period of time. Firstly, before they started chemotherapy, then after 3 cycles of chemotherapy, and then 1 month post-treatment, 3 months post-treatment, and then 6 months post-treatment. And findings from the first objective actually revealed notable gaps in awareness and practices. While oncologists and pharmacists were generally aware that chemotherapy could cause hearing loss, only a third of the nurses shared this awareness. And remember that oncology patients are very often in the care of the nurses when receiving the cisplatin chemotherapy prescribed by the oncologist. However, what was even more concerning was that even among the audiologists, there was limited recognition of their preventative role. Few identified pre-treatment counseling as part of their responsibility, and referrals for hearing assessments were typically made only after the patient complained of hearing difficulty. This highlights the absence of structured multidisciplinary collaboration and the urgent need for in-service training to define the roles, improve awareness, and enhance referral pathways. Effective ototoxicity management requires a team-based model in which each professional actually understands their role. Oncologists and nurses identify at-risk patients, provide assessments, provide initial counseling, and refer for audiological monitoring. But the audiologist is the one who is solely responsible for the entire ototoxicity monitoring program. They are meant to conduct the baseline and follow-up assessments, counsel the patients, and within their domain is the training of other health professionals. Pharmacists actually need to alert the team if the patient is also on any other ototoxic medication. Such collaborations actually ensure that hearing loss is detected and managed before it becomes functionally disabling. Now, the prospective cohort findings were striking. After 3 cycles of chemotherapy, that means the chemotherapy treatment was not even completed, 98% of participants showed measurable ototoxic change, even at a relatively cumulative dose of 150 milligrams per meter squared. Furthermore, HIV seropositivity was significantly associated with more severe ototoxicity at both 3 and 6 months post-treatment. And this suggests a synergistic effect between cisplatin and antiretroviral therapy, increasing the susceptibility to high-frequency sensory neural hearing loss. But despite these objective findings, many participants did not report hearing difficulties. And this actually highlights the insidious and under-recognized nature of cisplatin ototoxicity. The data therefore revealed a clear dose-response relationship with higher cumulative cisplatin doses of about 250 to 300 milligrams per meter squared, which were associated with greater hearing loss severity. HIV-positive patients demonstrated greater threshold shifts, meaning they had greater decline in hearing, as opposed to HIV-negative peers. The hearing loss predominantly affected the high and extended high-frequency range. And that means it often happened before the patient actually had any noticeable communication difficulties. And these results actually highlight the need for systematic monitoring, as relying on only patient-reported symptoms would miss the majority of early ototoxic changes. The third phase evaluated the feasibility of implementing this program within the clinical environment. And the program was found to be highly acceptable, with 91% of healthcare personnel and 89% of patients actually reporting it as beneficial. Scheduling appointments, such as dedicating 1 day per week to monitor ototoxicity, proved operationally feasible. However, you have to consider costs. With anything, you have to consider costs. Cost to the patient, cost to service providers. Cost to the patients included transport, lost income for the day. Cost to the service providers included personnel, equipment, and these are always critical to consider for the implementation and success of any program. But overall, the study demonstrated that having an audiological monitoring program is feasible, provided that it is contextually tailored and supported by institutional commitment. And implementation success, however, hinged on several key factors. 1, a multidisciplinary team approach, and clear delineation of responsibilities. Evidence-based protocols adapted to local realities. In-service training needs to be led by audiologists to enhance awareness and consideration of the patient context. Together, these elements shape a locally responsible and sustainable ototoxicity monitoring model. Despite feasibility, several barriers actually threaten sustainability. Human resource shortages, both in audiology and oncology. Equipment limitations, especially in our rural hospitals. Socioeconomic inequities, limiting patients' abilities to attend follow-ups. And gendered dimensions of care, where women's multiple roles and stigma may actually affect adherence. These challenges demand not just clinical solutions, but policy-led advocacy to ensure equitable access to hearing health services within oncology. Emerging technologies offer powerful avenues for overcoming resource constraints. Things like teleaudiology, mobile-based screening tools allow for more remote, cost-effective monitoring. And evidence-based from other South African studies demonstrate the reliability of smartphone audiometry and remote data collection. While issues of data cost and connectivity persist, teleaudiology represents an innovative pathway to expand reach, especially in rural or overburdened facilities. The findings carry significant policy implications. Integrating audiological monitoring into oncology protocols aligns with principles of equity, accessibility, and holistic care. The HPCSA 2018 guidelines, which are the national guidelines in South Africa, are largely based on the American guidelines. But this just provides a foundation. We require greater contextual adaptation to make it appropriate for the public health context. Audiologists must position themselves not only as clinicians, but as advocates, engaging policymakers, hospital administrators, and funders to institutionalize ototoxicity monitoring as a minimum standard of care. The study offers recommendations across academic, clinical, and research spheres. In terms of education, the undergraduate audiology curricula should actually incorporate ototoxicity monitoring within the burden of disease framework. In terms of clinical practice, audiologists must drive interprofessional collaboration and patient education for this patient population. Policy and systems, we need to have national adoption of screening tools and electronic records to actually track ototoxic medication use. And in terms of research, we need to look at having more longitudinal studies to actually monitor post-treatment hearing trajectories and quality of life outcomes. Ultimately, this research demonstrates the transformative potential of integrated, gender-sensitive, and contextually relevant audiological care. And to conclude, cisplatin chemotherapy saves lives. But without hearing monitoring, it can also silently take one of the most vital senses. The study revealed an overwhelming 98% incidence of ototoxicity, providing irrefutable evidence that audiological care must form part of standard oncological management. Women already face immense physical, emotional, and socioeconomic burdens. Adding hearing loss to this equation perpetuates inequity. Therefore, integrating ototoxicity monitoring is not optional. It is an ethical and public health imperative. As the World Health Organization 2021 reminds us, hearing care should not be a privilege. It is a right that underpins communication, inclusion, and dignity. Ensuring that women with cervical cancer retain their hearing is both a matter of science and of justice. Thank you.
Thank you for my presentation. My question is the cumulative dose of cisplatin 150 milligram per meter square. It's a single time dose, or generally we give 6 cycles of chemotherapy.
Yes.
Cycle, or the summation of the each cycle of cisplatin dose.
So each dose was about 50 milligrams per meter square, and then the cumulative dose was 300 milligrams. So we started seeing an effect as soon as they got to about 150 milligrams. So by the time they received 3 cycles of chemotherapy, their hearing was already affected. They hadn't finished the entire treatment, the course of treatments, but the hearing was already affected.
We send the patient after 3 cycles, then if any sign of ototoxicity, then we can switch to other chemotherapeutic agent.
Yeah. Yeah. But the only way you'll know it is if you have an audiologist within your team and all your patients are being monitored. And it's very important that they have the hearing test done before the treatment starts, because only then would you be able to identify if there's a shift in the hearing loss, in the hearing thresholds. Thank you.
I have one question.
Yes.
Thank you very much for your wonderful presentation. My question is, you selected cervical cancer with the cisplatin treatment.
Yes.
So you mainly focusing on the hearing loss of the female patient.
Yes.
But does it have the same effect in the male patient who are having cisplatin in another cancer?
Yes.
Do you have any data?
Cisplatin is highly ototoxic, irrespective of whether it's male or female. So there's a lot of studies that looked at males who had testicular cancer, and there's also well, cisplatin's been used for a whole range of cancers. So wherever cisplatin is, you would find an effect on the hearing. Even children, there's an even greater effect on hearing with cisplatin. Even if you reduce the medication or you change the medication to carboplatin, you find that there is an effect on hearing, but it is not as great as with cisplatin.
Thank you. So when we are giving the cisplatin and ototoxicity, we mainly focus on the nephrotoxicity.
Yes.
So if the kidney function is well, renal function is well, we never think about
absolutely
the ototoxicity.
And that is why I'm here today, to make you aware of it.
So thank you for enlightening us regarding the ototoxicity and your presentation. We have seen there is a grade 1 hearing loss, almost 80 to 90% of the patient.
Yes.
So my question, as a audiologist, how do you treat the grade 1 hearing loss patient, then grade 2 and 3?
So grade 1 would mean that obviously it's a very small effect on the hearing. So those patients, we typically would advise the oncologist to change the medication or reduce the dosage if possible. And if it's not possible, then we're going to advise, because we're seeing almost a very slight shift in the hearing. So a slight negative shift in hearing. So those patients, we'd advise them that they need to adopt compensatory communication strategies, like informing other people that they may have a hearing loss. Please get their attention before speaking to them, and to be aware and to constantly monitor their hearing. So to have the hearing tested like annually, if they're not part of an ototoxicity monitoring program. If it goes to grade 2, then we start to see it affect. When we fit hearing aids, we fit hearing aids when there's an effect on hearing or on frequencies up to about 8,000 hertz. But with ototoxicity now, the hearing loss starts from 20,000 hertz and moves downwards. It moves downwards. So by the time it gets to 8,000 hertz, then we would start considering things like hearing aids for the patient. grade 2, grade 3, it'll be hearing aids, and oral rehabilitation is where we train the patients to use their hearing aids and to be able to become effective communicators using hearing aids.
Thank you. Last question. So, the last question is, when a patient is diagnosed with cancer,
Yes.
and if I really need to give the cisplatin-based chemotherapy, and in a pre-counseling session, if I say to the patient that after giving cisplatin, you may have your hearing loss. And in that case, if the patient say no, I am having a cancer, and again, after treating the cancer, I'm going to be dead. So I don't want to take that treatment at all. So in that kind of scenario, in an ethical issue, do you think I should counsel the patient regarding the deafness or ototoxicity before giving the cisplatin? What do you do if you are a clinical oncologist for the patient?
The thing is, if you are treating your patient, you want your patient to be fully informed. You cannot keep away information from your patient. Your patient needs to be fully informed of all